Welcome back to Building Care Code. This is going to be a special episode together with my friend, Dr. Shlomo Saul. Shlomo is a good friend of mine for a bunch of years, is a doctor. And so I thought it'd be interesting to get your perspective on a couple different things I'm working on at CareCo, kind of big picture, just hear from your perspective. So appreciate you coming
thanks
in.
for having me on.
Yeah, pleasure. So you've been now practicing for how many years?
Like total, probably like altogether about 5-6 years.
And you're a primary care physician?
Primary care, family medicine,
Yep. So let's start really big picture. Like, what do you think? You chose to become a primary care physician. A lot of people these days are not choosing to do that. They're choosing to be specialists. There's a lot more specialists, I think, than there are today than there ever were historically. I think a lot of that has to do with the fact that there's a lot more data and there's a lot more things to study. And the PCP back in the day could cover basically everything, but now there's so much more knowledge and data and science that it's very difficult for the PCP. So let's start from like big picture. Why did you choose to become a primary care physician? And what do you think the state of primary care is today, for good or worse?
So I chose it. It was a combination of when I was in the Air Force, I was treating pilots. And so this was before I was choosing a specialty. So I was able to see what kind of ailments they had, and it was just kind of general stuff. And I got used to that, and I liked the idea that whatever they came in with, I was able to help them out. And so I kind of got used to that. And then to specialize in one thing is helpful because you're able to put all your energy in one area of study. But I didn't like that I wasn't able to do other things, you know? So primary care is kind of a surface level of everything. And you have to know you have to know a little bit about a lot. And so I like it. I think in terms of actual benefit to society and people, that's really where you're going to get the best bang for your buck. Because if you can there's a lot of preventative things that you can do. You can pick up diseases early. You can institute changes quickly. So, I like to find the problems in my office, not later on if they're in the ER and things like that. So, for me, it's the most satisfying aspect of medicine. So that's kind of what I feel about it. Yeah.
Fair enough. Let's double click on, you mentioned preventative care, and a big part of preventative care is looking out for and then managing down the line, if you don't catch it early enough, the issues with chronic conditions. Mm-hmm. So some of the biggest issues in this country, our biggest drivers of costs, are around obesity and diabetes, right, and hypertension, right, and different things like that. So yeah, what's your take on this? Like,
right. So we have a lot of diseases in Western society, and most of them are because of lifestyle. So you're going to have random events such as, cancers that are not caused by outside, just randomness. People will be unlucky. But what you're trying to do is, there's a lot of diseases such as metabolic syndrome. So obesity, diabetes, fatty liver, hypertension, high blood pressure, sleep apnea. These are a lot of things that are caused because of the way people live. So we can get into why it is, what the causes are, but they're eating foods that are not good. They're causing them to gain weight. Then those cause their body can't handle the sugar that's being put in. And so that causes a chronic disease. They're, let's say, smoking or drinking alcohol or overweight, and those all cause high blood pressure. Sleep apnea a lot of times is caused because of that weight. So a lot of these conditions are preventable, but because of the way we live, they're chronic diseases. So those are the ones you kind of expect because of the way the person's living.
And when you say the way that we live, are you referring to Western society in general, or America, the U.S. in particular?
The U.S. seems to be the worst one, just because of it seems to have to do with the food, the type of food we have, and the abundance of it, and maybe the times we eat. We're not exactly sure, but there's definitely diseases that exist here that don't exist many years ago and don't exist in other countries. And because of that, we've had to change how we screen. So for example, colon cancer, we do screening early in Western countries because of, it seems to be the diet.
Really?
Yeah. So like, if you have people who have like a high fiber, low processed food fat content, like the rates of colon cancer in Africa are very different than in America. So we moved our colon cancer screening from 50 down to 45 because we're finding younger people have these conditions.
Wow.
That is to say, overall, the way I see it is this is the way it is. I'm not going to be able to change society and what's available on your shelf overnight, but that's how you approach it, is like, this is the way the conditions are. So try to pick them up early, educate people about it, have them change their habits, and they can prevent a lot of these diseases. In addition, there's a lot of these diseases have a genetic component, a strong genetic component. So you'll have people who are extremely overweight, but their sugar's fine, and they don't have metabolic syndrome. They're just overweight, and that has to do with their genetics. And you'll find out, like, nobody in their family has diabetes, where somebody else is slightly overweight. They have a strong family history of diabetes, and then their sugars are out of control. So it's kind of an interplay between genetics and environmental factors.
So let's start with, once somebody has a couple chronic conditions, it's important that they then manage said chronic conditions, right? Can someone ever get past, like, get healed from a chronic
100%.
condition? Really?
100%. We have a lot of people now who are on these GLP-1 agonists, so like Ozempic and Zepbound and Wegovy, and those are they affect the hormones in the brain to make them not hungry, and also some other areas that it affects. But basically what happens is people start not being hungry, they lose weight. And a lot of the things, you start taking them off meds. They lose weight, their blood pressure is now a little bit low on a blood pressure medicine. You de-escalate them off, and now they don't have any high blood pressure anymore. Diabetes can be cured that way too. They've done studies where people who had insulin, and they had them on like some intermittent fasting diets, and they were able to reverse that. You wouldn't do that on your own, but these things are very reversible because they're caused by the chronic condition. Now, the problem is that a lot of these chronic conditions cause damage that then isn't reversible. So, for example, plaque buildup in the heart is very hard to pick up. If somebody, God forbid, has a heart attack because of that plaque, or they have a stroke because of that, or they get an amputation from diabetes, that's not reversible, Right. So the damage caused by these chronic diseases is not easily reversible, but the diseases themselves, like somebody could have diabetes, they control their sugar extremely well, they basically don't have diabetes.
Yeah. So I've gone through this exercise with a bunch of doctors throughout mostly on the Healthcare Trailblazers podcast, but would be curious to hear your thoughts. If you could choose, because look, when you're really young, at the end of the day, a lot of the stuff doesn't really matter because you can change very quickly, you heal very quickly, things like that. If you can catch patients at a certain point in their life and make them, like, let's take it by decade. If you could take a decade and say, this is a decade to get really serious about your life, you're really serious about your health, start making some serious exercise changes, some diet changes, some behavioral changes. What decade would that be in a person's life?
I would say, I have no data for this. This is just kind of my intuition, but probably from 40 to 50.
Yeah.
Because from 20 to 30, unless you have like frank diabetes, 20 to 40, probably all these issues are not really going to have enough time to cause damage. But after 40 is where you just start seeing these things, pop up. Like back when everybody was smoking and before we had cholesterol medicine, all this stuff, a lot of people were having heart attacks in their 50s because that's when these things caught up to them. So I don't know if that's a...
Yeah, no, that's the decade that I've come up. That's constantly the decade.
And that's when we start. Because a lot of recommendations.
In this country, we really only start taking it seriously in the 60s.
Well, a lot of the recommendations to start screening for like cholesterol, like regularly, is around 40.
Yeah.
So there's
Yeah. So let's talk about the management of chronic conditions. You primarily, from my understanding, you primarily operate in a fee-for-service world. You don't do a lot of value-based care like capitated or risk-bearing contracts, just in the place that you work.
Yeah.
So how has the incentive structure been for the actual management of chronic conditions? How do you feel that is in a fee-for-service world?
Right. So just to clarify, I work for a bigger network who does a fee-for-service.
Right.
And so it's not capitated or anything. I get paid either way, whether, but I guess you get RVUs if you see more patients. So that could be an incentive for me.
That's an incentive to see more patients, not necessarily to heal them.
Well,
or to care.
You could argue that maybe we'll just bring them in really, really early and very often, even though they don't need it, if you wanted to figure out a way.
Is it unique patients or encounters?
encounters.
Okay, so it could be the same patient over and over again.
Yeah, exactly.
Okay.
So, I mean, we don't do that.
Right,
But I'm
but
just saying,
practically
if you're
speaking.
coming up with a nefarious,
Yeah.
Anyways, so I guess your question is, how does that affect my management of their chronic condition?
How does the incentive structure, play out in your ability to manage chronic conditions? And if you only cared about the actual results
Right.
of caring for that patient, how would you do things differently?
Right. I'll be honest, I don't know how much it would change, because what I do and most doctors do and is we try to educate the patient on their condition as much as possible. And then we have recommendations, and we do it to the best of our ability. And then if it's a really uncontrolled condition, then they have to, like if somebody's sugar is, way high and you haven't to start them on insulin, you have to see them back in, a few weeks or a month, because just as the nature of if the blood pressure is high, out of control, then you have to bring them back until it's controlled, then you can kind of space out your visits more. Now, if the patient takes that medication or changes their diet or changing, I don't know about changing it for a fee for service or a capit, or a ownership, model would change. I guess I could spend more time.
The difference
with that,
there is just in the alignment of the incentive structure. So forget about my question about the incentive structure. If you didn't care at all about the incentive structure and you only cared about the end result of curing patients or making sure that patients don't come to see you at all because they're healthy, right? If you were trying to put yourself out of business, essentially, how would you care for patients with chronic conditions? Let's start with patients that have chronic conditions before we talk about preventing patients from maybe getting there in the first place.
So, say a question.
If I had chronic conditions, right? Let's say I had,
Sure.
God forbid, diabetes and whatever, CKD, right? And you only cared about healing me, essentially. How would you go about helping me manage those chronic conditions? And would that be any different than the way that you operate today? Like, would there be more care coordination, or how would you educate differently?
So if I had, well, let me just put it this way. My approach, now that I think of it, is to try to inconvenience you as least as possible. Meaning, you don't want to see the doctor every month,
right?
And if it's not necessary, then there's no reason to. So maybe somebody whose blood pressure is controlled, they can just see us every 6 months and get blood work to make sure electrolytes are okay, and that's fine. It's kind of an art to figure out how often somebody has to see you. Plenty of patients, I'd like to see them once a year. You're healthy, you're doing what you should be doing, your sugars are controlled. There's no reason that you have to be seeing and spending your time and money for earlier visits unless something comes up, So I try to inconvenience people unless they have they want to be seen for some reason more often. Once you're getting into patients who have chronic conditions, then the question is like, how seriously are they taking it? How much can I change in them? I've had patients who came in, didn't know they had diabetes. First time I meet them, we do check their A1C. It's out of control. They have all the symptoms, or waking up at night to pee. They're thirsty all the time. So, their sugars are crazy high. And a lot of them, the first time they hear it, you explain it to them, they're very motivated to change. And you'll bring them back to just have them educated about what it is, make sure they're up to date with what's going on. And then as they get an idea of what it is, they're working well, then you can space those out. And that works out for them really well. So to answer your question about how it would change, I don't know if I would change necessarily.
So actually, I have a better question for you.
Yeah.
You've dealt with probably hundreds, if not thousands of patients. And at the end of the day, the stack that I love to do is like, the bottom line is you're trying to create a better health outcome. In order to do that, you have to change behavior. In order to do that, you have to have a relationship with the patient, right? Mm-hmm. And that's why I'm super passionate about care coordination and doing it right, because you build that relationship via care coordinator. But at the end of the day, the doctor building that relationship is a much deeper relationship with the patient. Let's go to the tier of creating behavioral change, changing the patient's behavior. You have to really connect to the patient in order to do that. How have you found, like, I'm really curious, what's really curious to me is like, in your actual communications with patients, have you found certain ways or certain methods of communicating with patients that seem to be more effective in like, some doctors can just speak at you,
Right.
And there's no relationship and you don't care. Like a story that I've said a million times is, when my wife was having, I think, our second kid, this doctor walked in and it was Geisinger. So you don't have a doctor. You're on a schedule and you just see some random, rotation. And this doctor walks in and just starts giving my wife this whole spiel about which vaccine she should take and not take or whatever. And I remember just looking at this doctor and thinking to myself, like, we've never seen this doctor before. We have no idea who this person is.
Right.
Why does the doctor think that they have any better chance in this conversation than Google?
Right.
Like there's literally no, there's no, like, we don't know who you are. There's no relationship. So I think, I think you do a very good job with connecting with your patients. I know for a fact, just from being a friend of yours, that you're very passionate about, getting through to patients, and you actually don't like to waste your time if you don't think you're being effective.
Right.
So are there any things that you've learned over the years on how to actually effectively communicate to patients to get them to change their behavior?
Yeah.
And what are they?
So the biggest thing I found, there's two things, but the biggest thing I found is when you can convince somebody that, when they're convinced that you have a good idea of what's actually going on with them, then they will trust you because you kind of have a sense of reality. So, for example, if you have a patient who comes in and they're complaining of being very tired all the time, and then you feel their thyroid and it's large, and they're saying they're having, they're constipated, they're cold, their heart rate is low, and they all have all the symptoms of something called hypothyroidism, right? And so you suspect that's what's going on. You order the test, and the test come back showing hypothyroidism. So now you have them, and you want to convince them that they should take the medication, to replace their thyroid hormone. You're going to explain that it's going to help them. So when they start describing their symptoms, you get the blood work back, and then you say, like, hey, did you also have constipation? Were you also having, restless legs in that? And the more things you can anticipate them having, and then they're like, oh my God, yeah, that's right. Oh my, you've just now won their trust, because now they trust that you understand their condition because you actually do. As opposed to, hey, you have hypothyroidism, here's a medication, go. But when they trust that you understand what it is, then they will. It's a matter of trusting. So that way, if you say, like, hey, if you don't take this, I think this is going to be an outcome. You also have to be honest. Like, if they're diabetic and you say, hey, if you don't control your sugars, I suspect you might be having, you're not 100% sure, but we have to make sure your kidney function is going to be affected. There's a lot of things that can be affected. So not only just educating them about the condition, but anticipating and matching their symptoms what you know to be clinically true. Because you start off in medical school, you're reading it in a book. Then you see a couple cases, and you see more cases, you see outliers, and you get a good idea of what's going on. That way, when they come and they start saying their symptoms, you can get a good idea of it. You have a suspicion. So if you can connect what they're feeling in their body with what the story is in reality, you gain that trust. Then they're going to follow you and do what you expect. And
that's a really good point. Makes a lot of sense.
I just what I found to be the most effective. I kind of see my job, and I think a lot of doctors' job is to kind of take a lot of chaos that people have in their head, like, hey, I Googled 10 things because I'm having abdominal pain. And for them, it's a chaotic system, So if you can,
Gemini is trying to join our podcast here. Yeah.
Did I say Alexa?
I don't know. No.
So if you can give order to that, then that's really what you're helping. People are going to come and say, hey, I have this pain. They don't care so much about the pain. They want to know, is this going to be a life-changing event for me, or is this going to go away in a week? And you being able to give somebody order, that's what they're really there for. I want to get some order. What's going on? So the more you can convince them of the truth, because you're not selling a lie, you're actually saying something that you know. And when you don't know, you just say, I don't know, or you're going to investigate further. That trust is what really, and every patient's different. Some people don't want to get that information. You'll be surprised. Some patients are like, just tell me what to do. Some patients are going to be skeptical, but the majority of patients want to understand it and want to be given good advice. And when you mimic kind of what they're having and you are able to feed it back to them, I find that's quite effective.
Yeah, it's a really good point, because I think that like a lot of doctors probably don't want to go through that exercise because they know it in their head. And if I know it, then why do I need to say it? And then it just comes across as like, in the doctor's head, you've gone through all those things, but you know that that's the point, and then you just like spit out the bottom line. Okay, so here's what you need to do. But just going through that exercise shows the patient that you've identified really what's going on with them on another level. So I think that makes a lot of sense. What about digging deeper into like more of their background, like social determinants of health and what their environment is? Do you do a lot of that, and how do you feel that really impacts what's going on with them?
I mean, I could do it better, but you cannot. Well, first of all, for me, it's easier because I'm seeing the whole person. I think if you're a neurosurgeon, I don't know if it matters so much about what the person's, I mean, I guess their sexual habits matter, but like if they have pets at home, I like things like that are not as important in certain specialty. But for us,
like take our community, for example, the Orthodox Jewish community, right?
Yeah.
It's going to come with a whole host of variables and different things that are going to impact your health. So knowing that, I don't know, it could be as simple as like understanding the nuances of like Shabbos on the weekends. You're probably drinking, at least you're having a couple cups of wine, if not, whatever it is. Like there's going to be the ways that we approach things, our understandings about things, our view on things. So there's going to be a lot of things that also like family and support, and knowing that you have people around you, don't have people around.
So anytime you take somebody for the first time, you got to find out who's at home with them. And there's special ways of trying to ask that question. You got to find out like somebody who's single, somebody who's married, somebody who's in a good relationship, in bad relationship, if they have kids, if they don't have kids, if they're working, if they're unemployed, if they're disabled. These all matter. You can have certain diseases you actually expect or you are higher prevalence. So you got to get the social story. Obviously, alcohol, smoking. But the biggest ones are family life and what's your work. Religion's also important, especially like, if you have like more, like sometimes people, I'm like, do you drink? And they're like, no. I'm like, why not? They're like,
sir, need to drink more.
Well, let's say like a Muslim or, Latter-day Saints and all that. So religion is important. But social history is so important because people who don't have a good social network are at risk. Yeah. They're at risk for mental health issues and other things as well, but definitely mental health issues. You got to start screening better. That's our job to kind of judge. Yeah. So very important to get that. And then you want to try to get people, I'm not a psychologist, but listen, if I have a couple patients who are very good people, they're single. I'm like, why are you not dating? Like, I don't know, like there's no reason you should get out at least look into it, like it's healthy. We're social beings, Yeah. So you cannot ignore that.
Let's switch gears for a second. Careco, it's just interesting to explore. I think it's interesting for viewers even to just see the other side of being a doctor and the way that you think about things. So it's interesting to explore in general, but curious about your use of any kind of AI technology. Do you use any AI scribes currently?
Yeah, so use DAX.
Use DAX. Mm-hmm. Have you seen the new Copilot, the DAX Copilot, or not yet?
I may be using it. I don't know the name. It could be. I'm not sure.
So how has that experience been? I mean, it's new. It's a couple years old. Meaning
I've been using it for probably like a couple months. It's good because it will capture information that's being said there. You cannot ignore what's being written. You have to go over with a fine-tooth comb and remove a lot of things that it makes connections that are not there. It says irrelevant things. Like you'll describe a medication and where you're going to send it to the pharmacy and it'll put it in the note. Like you don't need people to tell you which pharmacy you're sending it to. So there's a lot that you have to go in and reword. So in our notes, there's objective and a subjective. Mm-hmm. So the subjective is kind of what the patients say, and the objective is what you think about what's going on and what your plan is. So the objective, we kind of have to change more often. The subjective, you just kind of read over and see if it's accurate what they're saying about the story and may take out irrelevant information or information that's not,
Do you find yourself spending more time fixing it than you would have just doing the note yourself? Or do you find that it's actually saving you time?
It is saving me time because it triggers my memory more. Mm-hmm. Yeah. Everybody's a little different. Like I do my own physical exam. I don't rely on that to kind of put it in because you have to like say, hey, looking in the ear and there's earwax and stuff like that. So you could say it and then remove it and put in your own words. But I find it helpful. I've come to rely on it actually, because you're not starting with a blank slate and trying to remember everything from the beginning.
Right.
So it is helpful.
I find that is a very common thing that people say, that like, even if you have to edit it, just going, it's going to do, let's say 0 to 9, and you have to do that last percent, but it's not just about the time, it's about the mental energy that it takes to construct the sentences completely versus reconstructing a pre-constructed sentence.
Yeah.
And just thinking about, which, and so, I mean, you're a doctor, so the type of terminology that you would use is probably going to come a lot more natural to you, but lower level clinical staff that are maybe writing documentation for you to see, right? And that's the space that we live in Careco. Yeah. It's a very, very high stress on them to try to think of like, how do I make sure that I'm writing with the right level of clinical terminology and level of conciseness and level of professionalism that a doctor is going to want to see. So
maybe I should bring up a topic actually.
Go ahead.
If you don't mind. Like, I feel like at least I feel like there's a little bit of a disconnect between the lower level, not the lower level, but the people who are feeding a lot of information to doctors and what is relevant to the doctor, as opposed to what is
what they think you
what,
want to see.
Where the effort is being spent. And I've spent a decent amount of time trying to, like we'll have new patients come in, and it'll be kind of important to know what meds they're on, try to get outside records, try to see if they've had screenings in the past. Not so much like, if they have a condition now, like the acute condition is kind of, I feel like there's a decent amount of information that's being given over that is not like as important as like the things
that you want to see.
Yeah, like I want to know.
So you want to see meds.
I want to see meds. I want to see specialty records.
Uh-huh.
So if you're seeing a specialist, that's very important for primary care because it's different. If you're, it's helpful if somebody's seeing something for a complicated condition. And social stuff, like we'll talk about the social stuff, but not as important as the kind of nuts and bolts of, we don't want to miss that this person, has a history of a rheumatological problem that they're being treated for. And like, at least for me, I like to know your whole story and which specialists you're seeing. We kind of take ownership of like, you're seeing these specialists, you're on these medications. We have to, my job is to make sure that you're not having two medications that interact.
Right.
Because if you see two specialists, they don't necessarily always talk to one another, especially if they're different networks.
Yeah.
So it's important to get, what procedures, like if they've had colonoscopy or not, so I'm not spending my time trying to convince them something they just had last year.
Right.
Get, some records like that.
Right.
So, yeah.
That speaks to, I mean, it's kind of ridiculous the way that this has happened, where you have all these different EHRs and the health system owns the EHR. I mean, this is now just like pure pontification, but I've talked about this a lot with a lot of folks who are like, in an idealistic world, what should happen is the EHR, the patient's chart, should belong to the patient in the same way that like you have your Google Drive, and then anytime you get files, they collect to your Google Drive. Like that's what it should be like. And instead of doctors allowing you to access your stuff, you should delegate out. But whatever.